Thank you very much for a kind introduction and for these souvenirs, which I'll take back with me with great pleasure. And thank you all for coming. I know that many of you had to take emergency leave from your other obligations, and I'm very complimented that you would think this might be worth your time. I'll try to live up to that. So let me say one thing at the beginning. When I talk about 35 years of contributions, I don't mean my contributions. This is not, how great I am. It's about work done by a group of my colleagues, and I'm one of them. And this is a branch of bioethics that is, I think, quite unfamiliar, even to people who study bioethics, even people who teach it. It's a branch of bioethics that sort of veered off. It had the same origins, people trying to think seriously about ethical choices involving health and healthcare, but it veered off, and soon there was a huge gap, and there wasn't much dialogue. Most of bioethics had to do with clinical decision making. Whether it's ever justified for a doctor to lie to a patient. Whether doctor-assisted suicide is permissible, these questions. But that's not what we were up to. We weren't asking that kind of question. And we weren't in the group of people who were asking questions about the permissibility of using new biotechnology, cloning or whatever. Those are all very interesting questions and worth discussing, but that's not what we were up to. And the people who were talking about those other questions, which was about 99% of people who were professional bioethicists, they didn't read our stuff. So, and I know that because I would look at what was on the agenda at their national meetings, and none of us were there, and none of our topics were either. So, okay, and I look in their textbooks in bioethics, and for the most part, they never mention us. Now, I didn't feel bad because we were really having, it was great, let me tell you. We were having loads of fun, and it was a time when we were very happy about our academic life. So it was a bit of a pity that our fellow bioethicists had never heard of us. But that happens. And we had plenty of other people to talk to. So what I'm going to do is review the stuff that we were doing, that I'm calling population level bioethics, which is not a widely used term, and also is a kind of not a very nice, not a very harmonious term, but I can't think of any other. So I'm going to talk about what this has been up to and how it differs from the kind of bioethics that most people do. And I'd be very eager to hear your thoughts on this. So let's talk briefly about, got that microphone problem. Is this better? I hope so. The origins of bioethics. It used to be called medical ethics. And I know where the word bioethics came from. Does anybody here know who invented that term? What?
Theologian?
No. It was one guy in particular. His name was Van Rensselaer Potter. And he was a kind of ecologist. And as it happens, he was a professor at the same university that I got my first job at, University of Wisconsin. What he meant by bioethics was something like closer to ecology or ecological ethics or something like that. But in the world of medical ethics, people who did medical ethics, they began to realize that not all their questions were really about what doctors do. It was a question, there were these questions about the uses of new biotechnology in ways that clinical doctors didn't have any role. And so they were looking for a better term, and here's this term bioethics. It sounded more general, so they adopted that. He was furious. I know because I co-taught a course with him. He thought they stolen my word. He never got over it. Um, so that was bioethics, but back then it was medical ethics. And where does that come from? Well, you can find discussions of medical ethics in many different traditions. I can't tell you about Chinese medicine, but if you look in Western medicine, going back to the Greeks, the oath of Hippocrates, of course, is still famous. But these were mostly conversations among doctors. So it was a question of how should we behave? And many professions have internal codes of ethics. The profession of people who do write insurance, the insurers have their own code of ethics. And so doctors have their own code of ethics. So there might be in the Hippocratic Oath that you have to put the well-being of the patient before anyone else's well-being. It always ranks first. Very important. That sounds very, very noble. But there are other clauses in medical ethics, like governing kickbacks. If you refer a patient to a colleague, should the colleague give you money as part of the profit that the colleague will get from having the new business? Well, should there be a rule against that? The American Medical Association was vehement. They said that would be unethical. So that's medical ethics too. Not all those rules are so high-minded. So that's how medical ethics was. But by the time the 60s rolled around, the kinds of questions that were coming up were questions that seemed too important to society to have doctors decide upon on their own. Some of them were questions about what is the basis for medical authority? And there was a rebellion against sort of high-handed paternalism and the assumption that the doctor was always right. And so, didn't the patient, for example, deserve to be told about the pros and cons of a proposed procedure in as much detail as the patient was prepared to understand, so that they could help decide, or they could decide really as a primary decision maker, whether they want it done to them. Well, my dad was a doctor, and in his day, that's not how it worked. Because how could it? They didn't know anything. The doctor would decide. Only the doctors had enough knowledge to decide. And they would decide for the patient, and they say, here's what we're going to do for you. Now, the patient may say, doctor, is there any alternative? Yeah, but none of the others are any good. That'd be the end of it. So there was this rebellion, at least in the United States, but in much of the world, really. Now, there's a cultural rebellion in China, but that was rather different, although not entirely different. It was, here these people of authority, what business do they have in deciding these things for us when we're the ones whose well-being is at stake? So there was a sense that this question was transcending the internal discussions of the medical profession. And now you start finding in the news on television at night, there'd be a big story about some bioethical question. That a patient was near death, and the doctors had said, okay, it's time to let go. And the family was saying, no, we want to keep the treatment going and be conflict. And the country would be, completely taken up in this question. The names of some of these patients would still be recognizable to older Americans. So the word bioethics now was used to describe a social debate, not just a discussion among doctors about doctoring, but a social debate. But it was still a social debate about doctoring, for the most part. Now, there were further developments. There were questions about research ethics that came from certain scandals in the United States. We've had cases in which there's now a general belief that human subjects were not properly treated. Some of these raised questions about race, which is almost always a big deal in the United States for historical reasons. So these questions about research ethics also became part of what bioethics is. Very important. And also new biomedical technology. For example, with the Human Genome Project, for the first time, it looked like a species of animals was going to be able to sort of look into its own nature and sequence all the genes, and what would happen then. And these seem like enormously important questions, all kinds of ethical issues. So who's going to talk about that? Well, bioethicists said, we'll talk about that. I was one of them at the time. So that was part of the rise of bioethics. Now, what is population level bioethics? Well, some of us began to be a bit, I don't want to say disenchanted, but we developed interests that went beyond that, because we thought, look, one thing is that what a doctor does in a clinical encounter is they choose an action among a certain menu of actions that are open to them. You know, they could treat the patient one way, they could treat the patient a second way, or they could decide to leave the patient untreated. But why is it that that was what was on the menu? The doctor didn't get to choose that. That was decided in some other way. Well, we know that a lot of the influence here is the health system. And so we thought, you know, the question about which choices the doctor and patient in a given clinical encounter should have, that's a really important ethical question. In a way, it transcends in importance the immediate question of how this doctor and this patient will choose among the options that are, in fact, offered up to them. So this got a lot of us interested in the ethics of health systems. And how come it was that the choices that were available were those choices rather than a different set or an augmented set? And recognizing that there are always scarcities of resources, then our question was, well, who decides how these resources will be used? And this is a whole new branch of stuff. We got very interested, but that still was tied to the ethics of health care. It said that the subject matter for bioethics is health care, either at the clinical level for, you know, what the doctor can or cannot offer to the patient, or at the system level, what the system allows the doctor to offer to the patient. But that's not the whole story, because why are we interested in healthcare? Well, for some of us, it pays our paycheck. That's nice. But for society as a whole, it's so we can stay healthy, isn't it? So really, health is what it's all about. It's health. You know, if we were perfectly healthy, if human beings were healthy for all their lifespan and then just, you know, keeled over, we wouldn't be talking about any of this stuff. So health is really what the subject matter is. And the realization that the primary subject matter should be health itself rather than healthcare, this was a kind of revolution. And that was accompanied by, in some ways, stimulated by work by social scientists who showed that if you want to understand why somebody or some group is healthier than another group, looking at the doctoring they get and the hospital care they get is part of the answer, but it's not all of the answer. In fact, it may be a relatively less important part of the answer compared to the other factors. It's impossible to come up with any real estimates, but one to throw out is 12%. Well, what accounts for the rest? So-called social determinants. So we know that, for example, in the town I live in the Boston area, people who live near the Charles River, which is the river that flows by Harvard, they live over 30 years longer on average than people who live in the poorest part of town. And in Washington, D.C., there's a subway that goes from one of the poorest neighborhoods, goes under the city, and it winds up in the richest neighborhood. And for every mile that it passes, if you were to surface and look around and survey life expectancy of the people who live there, it would go up by a year and a half. And between the starting point and the ending point, the gap is bigger than the average difference between the life expectancy of an American and that of people in the poorest 25 countries. So it's just enormous. This is just wealth. But with wealth comes a lot of other things: political power, the ability to avoid living near environmental hazards, the ability to choose jobs so that you're not at risk. The people who take dangerous jobs, that's not who lives in the richest part of town, that's for sure. And on and on. These things have a huge, powerful effect, especially with the bottom portion. There's a so-called fundamental causes theory of health inequalities that says if you look at the main risk factors for premature death in 1890 versus 1990, 100 years difference, what's on the list is totally different. So in 1890, it might have been tuberculosis and so on. And these things are completely gone by 1990. Nowhere in sight. But the people who suffer the most from them are the same people. That's what's constant. Whatever the threat is, it's the same people who get hit by it. Who are these people? They're poor, they're not well educated, they're not well integrated into society, they're the last to find out how to protect themselves and the least able to use that knowledge if they ever come by it. That's what's constant. Well, this is big news. And when we found this out, I mean, it certainly changed what I did when I found this out. I started writing about that. And this caused us, a group of us, the group I'm talking about now, to shift our focus away from just looking at healthcare and certainly just looking at the doctor-patient interaction. Instead, to look at the health of populations. What accounts for the fact that in some countries there's always variation, in how healthy people live and how long they live, but in some countries it's fairly narrow. In other countries it's wide. In some countries, it can be narrow or wide, but it's low. And in others, like Japan, for example, it's extremely high. Hong Kong is very, very high. So what explains this? And isn't that an ethical question? It sure is. And it's a question about the thing that really matters, which is health and life. So we thought, all right, this is a topic that deserves our attention. Well, what do we have to say about it? Turns out quite a bit. So let me say a few things just about what our focus was. As we said, we take a bird's eye perspective. Down on the ground, you're a doctor, you've got patients, and you have ethical choices to make when you interact with your patients. And that's pretty much your agenda for ethical decision making. And when you study the ethics of doctoring, that's what you're concerned with, quite understandably. Now, let's take this question about inequalities in health and social determinants. Does that enter in? Not really. You may notice that if you have some patients who seem to come from the poorest part of town and who come up in shabby clothes and who don't speak like an educated person, they tend to have all these bad diseases and they're chronic, and also that they tend to have bad habits and they don't follow your advice, all this stuff. But can you generalize from that to say, aha, now I can tell you about health inequalities in society? No, you don't have a big enough sample. You've got 2 patients like that. So what would you have to know in order to make a statement of that kind of generality? It's not going to be clinical bioethics. You have to look at the population level, get this bird's eye view. When you go up from the bird's eye view and look down on a population, you're not looking through the lens of an individual doctor to the patients. You're looking at patterns across the population. And that's what our primary subject matter was. Now, when we do that, as I said, we start looking at all these different determinants of health. And we realize that clinicians have extremely important decisions to make, but so do governments and non-governmental organizations. What they decide has a big effect on who lives, who dies, who's sick, who's not. And also on the way that people live in order to achieve those goals. Now, there's a natural expansion of our focus once we adopt this bird's eye point of view. In a way, now we're up in the sky and we're looking down on these populations, and so we've transcended the boundaries of an individual doctor's practice. But why stop there? Let's look at the whole health system, but why stop there? Let's look at the whole world. And when you start looking at the whole world, all the populations that are out there, big questions come up about why we see these patterns and not other ones. Most of the medical problems in this world, most of the burden of disease is in the poorest countries. It's not here. It's not in the United States. There's a famous story that a bank robber named Willie Sutton was asked, "Why do you rob banks?" He said, "Well, that's where the money is." Good answer. So why should a bioethicist be concerned about the health of people in the poor countries? That's where the bad health is. Same thing. Okay, so, and then the next thing is something that may not be obvious. Not only do you transcend national boundaries, you transcend temporal boundaries. So you can be concerned not only with the people who are alive now, but the next generation and the next generation, and the next generation. And of course, they don't exist yet, but they're gonna. There may not be as many of them as we have now because you guys aren't reproducing enough. But they're gonna, some of them will be there. And how healthy they're gonna be is something that is affected by what we do now. We know that. We know from WHO, for example, that 1 billion people will experience premature mortality before the end of this century as a result of smoking. And that's if we continue with our present trends in tobacco abatement, smoking abatement, 1 billion excess deaths. Just think how that number. If the 20th century was the bloodiest century in human history, with the wars and the genocides and all this stuff. And if you total up all the deaths that resulted from all of those horrors, it's only a fraction of the number of people who would die as a result of using tobacco in this century. And that includes all the tobacco smoking abatement programs that we now have underway, many of which are quite successful. So, boy, that's a big thing. Well, we're concerned. Some of those people haven't been born yet, but it's quite appropriate for us as ethicists to think, gee, if there are things that we could or could not be doing with tobacco control now that would affect whether or not our grandchildren or great-grandchildren, when they come into existence, will die prematurely from tobacco, isn't it an ethical question whether to do that or not? Of course it is. So now we're looking, we take a perspective that the philosopher Spinoza called subspecie aeternitatis, from the point of view of eternity, not as a member of this current generation, but sort of floating up there somewhere above all the generations and thinking about ethical questions that transcend generations. Now, this gets really hairy, partly because what we do now will affect who comes into being. And so it's very hard to calculate the rights and wrongs here, because when you reach your answer, it may change who comes into existence. So these questions are incredibly difficult. Nevertheless, it's irresponsible for us to ignore them. And I have a bunch of colleagues who are working on these things. I'll talk about that at the end. Now, a lot of these questions were addressed one way or another before bioethics discovered them. But what often happened was they weren't understood to be ethical questions. The people who would think about these are these global health people. For example, the biggest project in the history of global health is the Human Burden of Disease, Global Burden of Disease Study, which is now funded by the Gates Foundation. And it used to be in the driver's seat at WHO, and then moved to Harvard, and after that moved out to the University of Washington in Seattle. And they ran up against these questions, and they were stumped. They couldn't think of what further evidence they needed to solve them. Now, as it happened, luckily for them, in the same unit of Harvard where they were thinking about this. This is in the mid-1990s. There happened to be a resident fellow who was trained as a philosopher. Her name was Cicely Bach, B-O-K. She was married to the president of Harvard, Derek Bach, and she's also the daughter of Gunnar and Alva Myrdal, two of the founding thinkers of the Swedish welfare state. And Cicely was talking to them and heard them saying, God, we got these hard problems. We didn't know how to solve them. And she said, that's because they're philosophy questions. Those are questions they're not empirical scientific questions. Those are ethical questions. You need to talk to some philosophers. They said, oh, we do, huh? So they sort of put up a flag and said, philosophers wanted. They encouraged some of us to start coming over to their seminars. And I was one of them. And we didn't understand a word that they were talking about. They're working on these incredibly ornate and complicated issues of health measurement, coming up with measuring units like the disability adjusted life year that in one single unit can encompass how long you live and how healthy you are during that time, which turns out to be technically almost impossible. So we listened, very, very carefully, trying to understand what the heck they're talking about. Sometimes they would pause though, and they say, "Look, here's the question we've debated over and over again, and we can't make any progress." And they would state it, and we know something. Some philosophers have talked about something related to that. Well, they were very interested to hear about that, and they started inviting us to give papers. And they had a little conference where we did that, and they put out a book of this stuff. And that was really the beginning of a partnership with this incredibly talented group that continues to the present day. It's been 35 years counting. So the questions were noticed. They weren't called ethical questions. And one role that bioethicists had, it turned out, was smoking these out, identifying the questions that arose in population health, global health, that were ethical questions rather than empirical scientific questions, something that you could answer by doing a new measurement or an experiment. And that was, that you had to do that before you could make any progress with them. So this is as much a general introduction as I'm going to give. What I'm going to now do is just go over some highlights over the years. And again, let me emphasize, I'm not trying to say how great we are. I mean, I think some of my colleagues really were great. And I hold them in enormously high esteem. But that's not the point. The point is to show you that there's been all this work going on. Some of you may have heard of it or even know it well, for all I know. I'd love to hear from you. But many of you will not have heard of it, so this will be news. And I'm delighted to share with you the fact that it's been quite influential, as we'll see. In certain circles, that news hasn't gotten out either. So here's an early manifestation of this. That President's Commission under Jimmy Carter and Ronald Reagan, that was a new thing. It was a National Advisory Committee to report to the president on what would be the ethical choices involved in, it turned out to be 11 different areas. So one of them, for example, was, should someone who's brain dead be considered dead? And that commission wrote the report that resulted in 49 out of the 50 U.S. states adopting the brain death definition of death that the commissioners had formulated. But among these questions were questions about who should have access to health care. Because in the United States, unlike most civilized countries that have enough wealth, there's absolutely no right to be cared for if you're sick. Sad to say, but it's true. Many of us have been outraged by this. We know we're the outlier in this regard, and it seemed deeply unjust. So we were asked by the president to put out a report. We came out with a 3-volume report on access to healthcare, and my job was to put together the normative parts of this. So I invited a number of fellow philosophers and others to join a philosophy advisory board. And one of the volumes here includes their essays, which are still worth reading. And so that was an early one. But now notice, though, this is about the healthcare system, not about health. So it was before that revolution that involved switching our focus to health as opposed to healthcare. We didn't think of that. My colleague Norman Daniels also he got interested in this question of what would a just healthcare system look like as opposed to the one we had. He was one time asked by an editor of a journal to write an essay on is there a right to healthcare, a question which would only come up in the United States. And his first thought was, no, there isn't. I mean, he couldn't think of an argument that would show that there was. And after he wrote the first draft, he thought, oh, wait a minute, maybe there is. And he came up with a pathway to work through a philosophical theory of justice that the philosopher John Rawls had put out. And he thought on this basis, we could say that, yes, there is a right to health care or something close to it. At least there's a standard of what would count for a just healthcare system. And whether you want to say there's a right to healthcare involved, it's amounts to much of the same thing. So he wrote a book about it called Just Healthcare. And that was a very important first step. And then these things started coming. So the National Genome Center with Watson, one of the coders, discoverers of DNA, they got a huge amount of money from the federal government to start on the Human Genome Project. And they knew that when they went before Congress to ask for this money, which is the biggest, most expensive project in the history of biology, the congressmen wouldn't understand what this is about, but they would have one fear that these guys were going to create Frankenstein, monsters. So Watson was afraid that they would be turned down because this topic was too scary. So he decided to play a surprise card. He opened up by saying, I know that many of you are worried about what can happen. This got out of control. Let me tell you that for every dollar you give me to do the science, I'll spend 3 cents of that dollar on studies of the ethical questions. No one is more worried about this than me. And that worked like a charm. We gave him all of his money. Well, they gave him billions of dollars. This created the biggest fund for the study of ethics in the history of the world. They had buckets of money. Now the question was, what are we going to do with it? One thing they did was they asked me and my 3 colleagues, 2 of them who wound up at Harvard with me, to write a book on this, and this is what we did. It took several years, and it was the best funded research project I was ever on. We had a stellar scientific advisory board and all the rest of it. A little later, I went, as Roger mentioned, I spent time as the WHO ethicist. When I got there, I found out to my horror that WHO was about 30 years behind the times in genetics. There was only one geneticist on the whole staff, and he did single gene disorders, like Huntington's disease. They had no one who knew anything about the Human Genome Project and all this stuff. So a couple of people joined with me, and we went to the head of the organization, and we said, wake up. And they hired 3 outstanding academics to write a synoptic report on genomics and world health. And a big part of that is a consideration of the ethical issues involved. And the author of that, principal author, is my colleague Dan Brock, who joined me at Harvard. And you may not have seen this report because it was strangled in its cradle by the American delegation because they didn't like the friendliness of this group to opposing patents on genes. So, but it's available if you search for it. And I don't think it's been surpassed. It's just a very level-headed, illuminating report. Now, another area where the work of my colleagues became very influential was on priority setting in healthcare. And the way that they made their contribution was they looked at the methods that people who try to set priorities in healthcare were using in ranking one health need above another in terms of the social urgency of pursuing that solution to health problems. And there were many people doing this. There was a big problem because not all of them were using the same methods. So they were publishing articles about the cost effectiveness of this or that. But really, when you're setting priorities, the question is, how cost effective is this compared to that? And if the methods that they used to come up with the cost effectiveness ratio were different, there's no comparability, and you can't, those studies are useless. So maintaining uniformity across cost effectiveness ratio studies was key. And a panel was put together to try to accomplish this. It was the first author was Martha Gold. And it was later succeeded by a second edition. Martha Gold was not among the chief authors, but they colored the volume gold in her honor. Now, the thing I wanted to point out is that my colleagues, Dan Brock and Norman Daniels, were co-authors. It fell to them to write the ethics sections. And those essays have been very widely quoted. And what influence they had has a profound influence on how priorities are set. It's not one that the public ever hears about, but at the fundamental level, it's what drives the allocation engine. Their arguments matter. And after a time, in the 1990s, WHO got a new a director general named Gro Harlem Brundtland, who was formerly the prime minister of Norway and a graduate of the Harvard School of Public Health. She also had a medical degree. She knew all about these burden of disease people. And she said, come over to Geneva, leave Harvard, and we'll install you as the reigning methodology for processing numbers at WHO. And so, they all left, giving up tenured slots at Harvard, which is hard to do. And that had a huge influence. One thing is that the Burden of Disease Project, which is this enormously ambitious attempt to say for every human being alive on the planet how healthy they are and what risks they face, and to project into the future when they're going to die, and so on. It was starved for data. Lots of countries had no idea who died that year. The only reason they knew how many people who was born is that there were organizations like UNICEF who made it their business to find this out. And the result of that was that the health of populations was often presented in terms of life expectancy at birth or under 5 mortality. Why? Not because that's all that matters. It's because that's the only thing they had any numbers for. So they had this hugely ambitious project, but they were starved for data. But now they were invited into the WHO. Now the poorest countries in the world, they had people in the health ministry whose job it was to report to WHO on the numbers in their countries, but no resources and no training. WHO began to offer training so that these people were feeding data into WHO in a way that was useful for the global Burden of Disease Project. So this is extremely important. Part of that training was training in cost effectiveness analysis. And for that, they realized they had to include material on the ethical choices that come up when you design a cost-effectiveness analysis instrument and when you use one. Whose work did they draw on? My colleague Dan Brock. This was part of the textbook used worldwide for training people in the health ministries of the poorest countries on how to do their job. So again, huge influence at the very highest levels, but one that's totally invisible to the larger public and also to most bioethicists. Left. Okay. I'm just getting my started, but all right. So we found a huge budget of things to work on. We started a book series at Oxford called Population Level Bioethics. If you want to see the volumes, Google Oxford University Press and Population Level Bioethics. Here are 3 representative books for the series. Are these used in bioethics courses here or in the United States? I can guarantee the answer is no. Have any of you who are specialized in bioethics ever read one of them or seen one of them? I'll be amazed. But in my opinion, they're really good. And they're difficult too. Not that Nobel Prizes have any special significance, but the one on health inequality includes the work of 2 Nobel Prize winners. And at Harvard, we got a tremendous stroke of luck. The president and the provost decided that they would endow, or they would let us start up a program in this that spanned the entire university. And this is the agenda for our first meeting. And this continued for many years. Topics like these. This continued. We got another tremendous gift from the Brochet Foundation in Switzerland. They said every second year we can come there and convene a conference on topics we think are important, and they'll pay for all the expenses of the experts. And we've been doing this for well over about 14 years, I think. And some of these have been tremendously useful. Here's a recent one. The Lancet Commission was asked to tell the world what are the principal threats to human health in the rest of the century. And so, as I said about trying to answer this, they called on our group, and we've responded, and our report is under consideration at the Lancet. You'll see it soon. Okay, so now that's really my survey. What remains is I can give a few examples of the kind of work we do. But to tell you the truth, I'm now suffering from jet lag. So I'm going to pull that chair over here and I'm going to sit down and hope that the microphone will reach me. And rather than rattle on about each of these things, which I'd be happy to do if that's what you want me to do, I'll ask you if you have any special, thank you very much. If you have any special requests, let's see how we're going to do this.
You have a handheld mic.
Great. Okay. It works. Okay. Good. That stopped me from falling over, which is very fortunate. Okay. Thank you. Now, the only problem with this is that the bright light makes it impossible for me to see who has their hand up. So now it's better. Okay. So what I've done is to describe a branch of bioethics in which there are a number of really serious scholars. The center of gravity here was mostly at Harvard, but it was also, there are several other institutions that were doing this. And I hope that I've showed that what we did had a big influence on a lot of people whose work had a powerful impact on the way health and healthcare are managed throughout the world. And as I say, I'll be amazed if any of you have know a thing about what anything I've said. So maybe I'm deluded. Maybe this work is worthless, and we've had no influence whatever. But if that's true, that's news to me. Uh, so what I have here is 4 examples of work that we did, and I can go into great detail about these. In some ways, that would be the most useful part of this lecture because it'll show you what we actually did in trying to do this. Because what I've said so far is I said we did it, but it's a black box. You have no idea what that really amounted to. So if you'd like me to, I'll go into that. But I'm pausing at this moment to ask, anybody prefer to do something else? Yeah, of course.
Maybe I can pick one.
Thanks, Tony.
No, great. Thank you. Thank you so much. I mean, I fully agree with you. I think it's probably one of our most important areas of ethics that doesn't really get covered. I mean, the health systems you touched on at the beginning, I think is very interesting because you allude to US. We know that US, I think, with the last figures, they have spent about 18% of GDP on health and don't have good health outcomes.
18.
18, yeah.
Yeah. I thought I heard
Here in Hong Kong, we spend about 5%.
Yeah.
About 2.5% is spent by the government. The other 2.5% is in the private sector, and yet the healthcare outcomes are way better. So I guess if a clinical doctor is unethical, I guess as the medical council, they can call the doctor to account, and potentially the doctor can lose his license. I mean, I guess if the health politicians who are making maybe unethical decisions on healthcare provision, do you have any sort of insights into terms of how we can hold them into account for being unethical?
So that's great and profoundly important question, to which I can only give an answer that would be so long that we don't have time for it. But let me just caution, from the outside, it's inexplicable. When you're spending 5% of GDP here and you're achieving better health outcomes, we're spending 18%. It's probably higher now, by the way. How could that possibly be? How could that possibly be? The answer is partly historical, and it's a surprising history. And let me just give the beginnings of that story. It's that during World War II, there was a manpower shortage, labor shortage. And so the government feared there would be inflation in wages because the few workers who were available could say to their employer, look, your competitor is offering me more, I'm leaving. And that could cause a spiral, which would then cripple the economy. So to prevent that, they had stringent wage controls. But the shortage of labor didn't disappear, of course. And each firm that used scarce labor now had to figure out how to attract workers to their place of employment. There was a loophole, though. They weren't allowed to offer higher wages, but there was no regulation. There were no controls on the benefits that they offered. In fact, more than that, there was a specific tax preference from the workers' point of view. If they got benefits like health care through their employer, that would not be counted as income and would not be taxed as part of their wages. So one way it could have worked is to the old way, which is, you pay the worker a wage, and from that they buy services in the private sector. Okay, well, if they're using wages for that, they're going to be taxed on those wages, so they have less money to spend on the doctor. So in effect, it would be much more expensive care than if the employer provided it, because that would be untaxed. And so the same number of dollars spent on the healthcare could give them a lot more healthcare. Once the employers realized that, they all started offering healthcare as part of their wage package, except that it wasn't called wages and it wasn't taxed. Now the war ends, and again, there's a post-war boom. So even though there's abundant labor now, the need for labor is still acute because there's all this expanding economic activity, and they continued. There were post-war wage controls, And again, the employers used healthcare benefits as a way to get around that. And that's what created a tradition that we've never stepped away from, where the primary basis for your healthcare insurance, or for who's going to pay for your healthcare, is your employer. Now, that has some advantages, but it also has a lot of advantages. And one thing is that it's very hard for the government to reach in there and exert controls in the name of what's in the public good. It becomes part of the contract labor at negotiation time. And it proved to be impossible to control prices during that time. So, every time that a union would meet with General Motors or whatever, they wanted more healthcare benefits because, hey, the dollars spent on that were worth $1.50 to them because it wasn't taxed to their members. And so it just kept going up. And as healthcare got more powerful in terms of the technology involved and the range of things that doctors could do for you, maybe, then that became an especially popular way of getting paid. And so healthcare just inflated. Now, this then joins the second big historical thing about the United States, which is both a virtue and a flaw. Anytime there's a public policy question, there are a lot of people with a thumb on the scale. Our political system has many openings for exerting influence, which is good. It's democratic in a way. A lot of people who would be affected by public policies have a say in what happens, but it also has some terribly negative effects too, which is that the more well-entrenched an interest is, the more it can exert its influence in a way that's contrary to the public benefit. And one of them is in healthcare. It's fabulously just an oil well, a gusher, a gold mine. There's huge profits to be made in healthcare because remember, we spend 3 times as much as you do. Everything is much more expensive. Now, I have to do a confession here. I'm part of the problem. I'm part of a healthcare institution, the Harvard School of Public Health. How come this area of American life, public health, they have enough money to pay people like me to talk about these abstract questions? Well, that's because there's so much money sloshing around, they can do that. So I'm part of the problem too. But a sobering fact is that if you look at inequality in America, not just health inequality, but overall inequality, especially income inequality, a major driver of that is wages for doctors. Doctors are by far the highest paid of the major professions, and they earn so much money that the money just going to the households of doctors is a big part of why we have these huge inequalities in income in America. Now, do you think the doctors want to give that up? They do not, in case you were wondering. And neither do any of the other people who are siphoning the system for money. And there are lots of us. So once it got entrenched, you just try to take it away. They're not agreeing to it. So when we have debates in America over the health system, it's always on how to expand access to it or how to fight off efforts to decrease access to it. No one talks about the underlying elephant in the room, which is why it's so damned expensive. So I sometimes go to international meetings where there are people from many countries talking about their budget problem. That they said we can't spend another kroner or pound or whatever it is on healthcare. We're up against the limit. I say, how much do you spend? Oh, 5%, 7%. So I would ask the question, well, look, suppose you added 2 more percent, which for Hong Kong would be over a 40% increase, right? Or a little less than anyway, a big, huge increase. Well, the answer I get is, oh, well, then we wouldn't be up against the limit. There'd be no rationing at all. I mean, we'd have to beg people to come in and use healthcare. And I say, okay, but you're talking to someone who comes from a country where we spend 18%. And you're saying you can't go from 5 to 7 or from 7 to 9? I mean, come on. So what do you think I say? They just stare at me. Which shows how perverse our system is. I mean, there's no reason in the world it should be costing that much, especially our outcomes are poorer. But that's the way it is. And it's as I say, this wasn't because anybody thought this would be a good idea. It's for historical reasons. And once it got entrenched, it's there. Now, of course, the solution is to adopt your system. We should have by and large, a single payer system for, that maybe helps the private sector for stuff that you can't get in the public system. And there we can set prices and so on. But, there's this thing called path dependence. There's some policies that would clearly be the better policy, but it's only a policy choice available in contexts where that really is a policy choice. And given that we've gone down the road we've gone down all these years, that's not one for the United States. So there are a few politicians, some of whom are good friends of mine, who regularly say we should have a single payer system in the United States and model it on the National Health Service and in the UK or some other good model. And of course they're right, but they never get anywhere because it would be upsetting all these people who have influence not just in the healthcare system, but in the elections. They will vote with their money and they got the money. And there's no way that's going to happen. So that's my short answer. Crazy, huh? Don't ever emulate us.
Anyone else has any burning question? The moment.
Okay, in that case, how much time do we have now? We have
How many minutes?
all right.
Okay, till the end, yeah.
All
20
right.
minutes.
So start with some of these examples. I'm going to start with a really simple one. Now, what I'm going to give you is you should understand this as a kind of intellectual exercise because the factual assumptions that underlay this turned out to be wrong. But that doesn't matter because I'm just using it as the kind of thing we do in this field. So Wyeth Corporation had a vaccine for rotavirus called RotaShield, and it was about 1 million kids in the United States and some European countries were given this vaccine, and it really helped with the rotavirus. Kids who would have been in the hospital with rotavirus now experience nothing. But it had a problem, which is that in about 70 cases, clinicians thought that they saw a very non-benign development in some of these kids. Part of the bowel started turning in on itself, something called intussusception, which was seriously required surgery. Now, was that the result of having taken this vaccine or not? Well, of course, this is all when you get a vaccine to 1 million kids and you get 70 cases of this. Well, how many cases per year were there without the vaccine? Well, there were some cases. So proving causation is incredibly difficult. But the thing with vaccines, as we all know, is that it's very hard to persuade parents to allow you to shoot something into their kid when the kid is perfectly healthy. And if, God forbid, if that should make the kids sick because they weren't sick before, it's what you did, doctor. Now, all vaccines make some kids at least a little bit less healthy than they were, or at least it causes pain or something. So it's always a question. But there's hardly any margin for error here. The ratio of benefit to harm has got to be overwhelmingly favorable for the vaccine to be accepted. And in the United States, the thing is that rotavirus, which causes, it's a factor that makes diarrhea, potentially a big problem. It doesn't result in many deaths because if a kid gets really serious diarrhea and you can't do anything about it, they go to the hospital, get an IV drip, and they always survive. So I couldn't agree more. So
Just see.
all right, so with that meant that why I thought this isn't the time for this vaccine, they pulled it. Okay, fine, no problem. This has happened before. Now, it may be that the impact on population health was adverse, a lot more kids would be healthy if they'd had the vaccine than not, and it would have sort of drowned out those 70 cases, even if they all were the result of having the vaccine. But that's not the way you do it with vaccines. So, okay, the vaccine makers are very used to this. But how about the rest of the world? You look here. Damn it. Oh, there's back. Okay. Here are the base rates. What we want to know is how many kids are dying from rotavirus? Well, in the United States, not very many, right? But you go to Central Africa or to some countries in Asia, a little bit in Bolivia, let's say, it's huge numbers. Millions of kids are dying all the time. So should they get the Wyeth vaccine? There was a session at WHO which I attended, and it was amazing. They had brought in the chief officers from the drug control agencies of countries from around the world to talk about this. And one after the other, they said, we could not approve the Wyeth vaccine because what we'd be accused of is they would say, look, the Americans decided it wasn't safe enough for American kids, and now you're saying it's safe enough for our kids? So you think that our kids are not as valuable as American kids? Now, if you look at the website for the Gates Foundation, they have a slogan, the equal worth of lives. Every life is equally valuable. So, here are these, the drug regulators are afraid of parents are going to say, you don't think my kid is as valuable as those American kids. So you're going to okay that vaccine that Americans said wasn't safe enough for their kids, weren't you? And they said we just couldn't get away with that. Well, that means that they're understanding the moral argument in a certain way, which is that they think that this principle of the equal worth of lives, it means this, that if Rotoshield isn't safe enough for American children, it's not safe enough for our children. But if you look at that moral reasoning and think about it, you might have said, actually, the principle of equal worth of life should be understood quite differently. It should be termed, it shouldn't be equal safety, it should be equal benefit. That equal worth of lives means that every child deserves the treatment that offers the most net benefit. That's what the equal worth of lives principle, which is a good principle, does require. And in this case, you can't ignore the base rate. It was really true that millions of kids are dying from rotavirus. That's got to affect your decision about whether to approve a vaccine that may have caused some harm in some kids. It has to. If you ignore it, you're crazy. Or that's what we thought. One colleague of mine sort of did a back of the envelope calculation about what the net health impact of it would be for not adopting this vaccine. They said it would be millions and millions of children over a decade who would die because you didn't approve the vaccine. Can that be good? So this is a very simple example of a population level question in which moral reasoning turns out to be a very important thing to do because millions of lives depended on it. And according to this exercise, millions of lives would have been lost if the assumptions were correct. I'm not going to go into what assumptions were wrong here because that's an example. Okay, here's the second one. This global burden of disease project, I've already talked about it. It's this hugely ambitious attempt to construct a map of all the people in the world that says, here's how healthy they are, here are the risks of their health, here's how likely they're going to be to have a long and healthy life, and so on. The most ambitious global health project ever. Some of you, for all I know, are contributors because there are about, I think, 7,000 scientists worldwide who are now participating in this. No, that was developed by this group led by Christopher Murray at Harvard. And then, as I mentioned, it moved to WHO when Dr. Brundtland became the Director General. First thing he did was they were looking for this unit of measurement, the disability adjusted life year, which they invented. And they wanted to get it exactly right because everything depended on it. And they put together a mammoth conference in Marrakesh It's called a summary measure of population health, and you can see why it got that name, summary measure, because it summarizes the health of all the data about the health of a population in just a handful of numbers, really. You can think of it as something that distills 10 million medical charts into just a few numbers to give you an overall picture of how healthy a population or a subpopulation is and how healthy they're likely to be. And later on, they hoped it would tell you how healthy they'd be if you did this as opposed to that. So they put this together. Now, the amazing thing is that this book, by the way, is also available on the web for free, and it's still worth reading. And let's see, sorry. Let's say here. If you look at the table of contents for this, amazingly, there's a big ethics section. And these same people, Dan Brock and so on, my colleagues, they wrote essays for it that were so illuminating. And their colleagues at the CUHK conference, they were listened to very, very carefully. And what they said influenced the way people thought about it from then on. Now, the first synoptic attempt to sort of say, here's what this global burden of disease things looks like was a volume that came out with the imprimaturs of the World Health Organization, Harvard School of Public Health, and the World Bank. And Chris Murray was the co-editor, and Alan Lopez from WHO was a co-editor. And this, too, had a big chapter on ethical choices. Not written by an ethicist. Murray is just one of the near genius people that I know. And he wrote it, but it was an excellent discussion of ethical problems that he was wrestling with that he didn't have answers for. Still worth reading, by the way. Now, as I say, our group got involved with them. They brought me over to WHO, so I was working with them for a couple of years on this. And then after they were coming back to Harvard, we had repeated conferences. The global burden of disease had many different iterations. And one big one, the third major one, was in 2010. Now, leading up to the publication of this iteration of the report, after they'd done their estimates, I got a phone call from Christopher Murray, now who's living on the other side of the country. He said, Dan, fly 20 of your colleagues to Seattle immediately. We have a problem. He said, we have these ethical choices. They're forks in the road. We can go this way or we can go that way, but we have to go some way. And depending on which way we go, the numbers that we report, like, how severe is the problem of heart attacks in Poland? It could vary by as much as 400%. Now, I can explain to you why. Well, just for those of you interested in the details, this is the fact. This was influenced by two things. One was whether or not, when you take account of the impact of a disease over a long period of time, you treat each year equally, or whether you count what happens in later years a bit less. That's called temporal discounting. And the second thing was they were having real troubles getting this oil and water to mix. That in the disability adjusted life year unit, they were trying to mix duration, which is something that happens over time, how sick you are during a given period, with something that happens at one instant, which is death. Either you're alive or you're dead. And it turned out, for a host of reasons, putting these together in a single measure was causing no end of problems. So one proposal to get around this was you take all of the burden that something like cardiovascular disease imposes on a lifetime, and you record all of the burden as occurring in the lifetime of the person at the moment at which it begins. Now everything is instance. Well, if you do that and you don't do discounting, it turns out heart attacks, cardiovascular disease, is 4 times higher in its degree of burden than if you don't do either of those things. And that's, sometimes if you're telling Poland what the trends are in your country, and you say diabetes is up by 5%, they all get hot and bothered. Imagine if you told them that the burden of heart attacks had increased by 400%. And then they said, what? We don't see any of that. You say, oh, that's just because we calculate it a little differently now. That's not what they want to hear. So they invited us in, this is the methodology paper. This took up a whole issue of the Lancet in 2011. And they talk about the consultation. It says here that there are all these problems here. They list a bunch, which I won't go through for reasons of time here. And they say that for this, we brought in a consultation of 21 philosophers, ethicists, and economists, and they called it the critical ethical choices for Dolly's meeting. Well, they did change, they made decisions, they had to make decisions on all these questions, and they did. And they attributed a lot of it to what we said. I think they exaggerated, I think, actually, but that's still nice to be credited. So this is an example. This is stuff that, some of the people working in our little vineyard, some of whom do work that I don't even understand. They've been doing this, and now they were called on by, this global project to feed into the decision-making process at a crucial moment. And according to these people, it steered them certain directions rather than others. So that's a profound influence that, again, escapes notice for most people. Now, I only have probably 4 minutes left or something, so I'm going to just speed skate through the rest. In the year 2000, WHO did a bold thing. It ranked all the world's health systems from number 1 to 199. The United States came in 32nd and got widely ridiculed for that. Now, what was the basis of the ranking? There were 2 principal bases. One is how much extra health the health system added to the population. And the second was how evenly that was spread across the population. There were certain countries that where the health system actually had a huge effect on population health, but it was concentrated in the most fortunate groups, and they got downrated. Brazil is one example, and surprisingly, China was another. And in China, at least, I was told by Chinese health officials that when they saw that, they thought, whoops, were they very proud of the advances they made, but when they saw that China had slipped way down in the rankings because of the inequality of it, unevenness of its positive impact, that's when they said we got to reinstate rural health insurance, and that's why 800 million Chinese got health insurance. One reason anyway. Now, where did all this come from? Well, in order to be able to measure the degree of inequality in how a country distributes its medical benefits, they had to come up with an inequality of health measure. And to start off with, they all started with, they asked me, where should we start? And I said, well, get the guy who wrote the book. These are my colleague, Larry Temkin, a philosopher who wrote this book on inequality. Within a couple of weeks, Larry Temkin was in Geneva giving a talk and conferring. And one thing led to another. I would take you through some of those steps, but it's a bit too complicated. But that, again, had a huge impact. Let's see. Oh, I'm going the wrong way. Sorry about this. I know how confusing it can be. All right. So another one, quickly. When in 2010, WHO decided noticed that some countries like Thailand and Taiwan, middle-income countries, had enacted a national health insurance scheme. They thought, whoa, this is supposed to be something only rich countries do. And they conferred and they thought, okay, now we think every country can do it. But how? And so that began, they said, this is our number one goal, is that every country should have national universal coverage. But of course, getting from where they are to that exalted state requires a lot of steps. So they again convened a group of us to advise them on how this should be done. What's a good way to chart out this pathway, and what's a bad way. And we met repeatedly, and we came up with this is the group. And we came up with rather complicated methodology that involved, took into account GDP per capita. Basically, what it says that if the country is so poor that they're putting hardly any money in, then cost effectiveness has to be numero uno. But the richer the country, the more of GDP that they can they can devote to healthcare. Now you can start taking into account other distributional concerns, and that might start trumping after a while. And and this is how this thing worked out. So, for example, TB treatment came out high, and with asthma treatment medium. Surprisingly, dialysis or renal failure came out rock bottom. Now why? It's because it has hardly any net effect on population health, and in the poorest countries, they just can't afford it. Even though it's a life or death thing, if people don't go on dialysis for the national plan, they die, and the family will never be quiet about it. But we said it would be malpractice if you're putting together national universal coverage to include kidney dialysis among the benefits. Now, when we had a draft report saying this, we were told by many people in WHO is going to reject this immediately. It's just not what they want to hear. The member states, they all want to hear that if you enact universal coverage, everybody gets these impossibly expensive treatments paid for. And especially when it's a life or death. And this is the best example of it. To our amazement, that didn't happen. WHO was accepted the report without any changes. And then, highest compliment, the new Director General plagiarized our report, publishing an article that just lifted out our analysis and then signed her name to it. We thought, we're there. That's great. Okay. Okay. Now, Roger asked me if I had mentioned when we were talking about topics that something I do talk about these days is, this flood of disinformation that's making our jobs impossible. And it was that or the other one. And I said, well, I think I can combine both. I was wrong. I can't. I'm out of time. So I'm going to stop. I've got some things to say about this, but I'm going to stop. And I'll thank you very much for listening as long as
Thank you very much. Do we still have time to take one more question maybe, or not really? Oh, 12:30. Okay. Well, if not, maybe what do you think is the take-home message of your talk today? Because every jurisdictions face their own problems, of course, and some governments may not even think that, oh, these are ethical questions. Obviously, it's very obvious to us, but not to them. What are you going to say to that?
Let me just say, last night I was treated to dinner by, Roger and several colleagues. We had a terrific discussion about this, and it turned out we saw this very, very differently. So one person at the table blamed public health for the problems of noncompliance, the rejection of COVID control measures, and so on. Is that it's because we were so arrogant and high-handed, and we talked down to people, and people just got sick of it. All right, that's one explanation. There's a totally different one. We've always been high-handed and arrogant, but that by and large the public would do what we said that had to be done. That's what's changed. Is the public response to our arrogance and high-handedness. What accounts for that? And an alternative explanation is it's the result of a deliberate policy of disinformation and attempts to sow chaos in the social order on the part of some very bad actors on the international stage, some of whom are located in St. Petersburg at a certain address I can give you. Now, excuse me, just one thing. We've had disinformation campaigns going for decades. The biggest one in America was tobacco. They said, what do you mean smoking causes cancer? And they'll have some doctor talking on the television. I tell my patients, smoke Camels. Oh, yeah? Of course, that doctor died a long time ago. But now, this is all lies, and they knew it. Why were they doing it? Because they wanted to sell cigarettes, of course. So that's why. Okay. Now, same thing with fossil fuels. We're cooking the world. Our grandchildren will be sweating it out every damn day. And the industry, fossil fuels industry, has been pouring out disinformation, trying to get people to believe that climate change isn't real or that nothing can be done about it or something. Why are they doing that? Because they want to sell, petrol. That's why. So, all right. So, and the same thing happened with asbestos and lead and all these dangerous products. So we're used to it. And here are two wonderful books that was written about it. The tactic is always to create doubt, to get the public to think that experts disagree, even when they don't. Because that undercuts medical advice, expert advice, because the experts disagree. And they're really good at this. But when COVID came along and there was this flood of disinformation about COVID, I thought, wait a minute, there's one thing is missing here. I understand. You lie about whether smoking causes cancer because you're going to make money on selling cigarettes. And you lie about whether or not fossil fuels are going to raise temperatures in the world because you make money selling fossil fuels. Who's making money on COVID? COVID doesn't have there's no COVID producing corporation that, that wants that to be not, taken seriously. Who's doing it? What could possibly be the motive for all this disinformation? And I came to the belief that the answer is a political motive. There are certain parties that think they'll come out ahead if much of the world is completely convulsed with social acrimony and challenges to expertise and rejection of the established political order. They'll come out ahead. And that might account for why it is that our arrogance is suddenly causing all this distress. So that's me.
Thank you. Thank you very much. Please give a big hand to Professor Daniel Wikler for the illuminating talk. Thank you very much for being here. Thank you. Have a good day.